Today's episode is brought to you by Audible. Get a free audiobook download and 30-day free trial with over 180,000 titles to choose from for your iPhone, Android, Kindle, or MP3 player. Go to audibletrial.com/FUMS. Welcome to the FUMS Now podcast show, where you'll gain information, inspiration, and motivation for living your best life with multiple sclerosis. Find us online at FUMSnow.com. I'm your host, Kathy Reagan Young. Today I'm chatting with Dr. Victoria Leavitt, a clinical neuropsychologist and director of the Multiple Sclerosis Cognitive Neuroscience Laboratory at Columbia University Medical Center in New York. Whew, that's a mouthful. We're talking about Cog Fog, that horrible, insidious rat bastard that sneaks up on us, embarrasses us, and renders us unable to function. Dr. Leavitt knows a lot about Cog Fog and what we can do to try and help ourselves. Let's get into it. Dr. Leavitt, thank you so much for being here with me today, and welcome to the show.
Thank you.
Let's start with a few definitions, if you don't mind. Cog Fog, as I call it, is identified as things like word fishing, confusion, fuzzy thinking, memory lapses, difficulty reading and comprehending, having a great deal of difficulty multitasking. And you're a clinical neuropsychologist specializing in cognitive neuroscience, right?
Correct.
Could you please break that down for us a bit? What does that mean, and what do you do exactly?
Sure. Well, first of all, the most important thing to say is that I specialize in multiple sclerosis and the cognitive symptoms experienced by people with MS.
Excellent.
So taking from within the huge field of cognitive neuroscience, which looks at things like aging and dementia and all the different ways that our cognition can be impacted across the lifespan, I actually specifically focus on people with MS.
Okay.
And so the ways that they experience what you're calling Cog Fog are vastly different from one person to the next.
Mm-hmm.
Just like with every other symptom of MS, we know that the particular constellation of symptoms that any one patient experiences can be entirely different from another. You just listed a quite comprehensive selection of the types of cognitive issues that people with MS experience, but not everybody experiences all of them. Not everybody experiences any of them. Mm-hmm. And I'm learning along the way a lot about the types of things that people have problems with because, frankly, they're not all on our radar. So the things that we talk about, scientists on the other side of the equation, we always talk about information processing speed and memory as the primary cognitive deficits. Mm-hmm. And when we say information processing speed, that sounds sort of like something that your computer has to deal with, but right. Our brains also have to deal with it, right?
Right. Yeah.
Everything that we do is reliant on efficient transmission of information across our brain. Mm-hmm. So those are really the two domains that we focus on in research, but that's not even the tip of the iceberg in terms of what people with MS describe to us.
Mm-hmm. And so what exactly is a clinical neuropsychologist, and what do you do, I guess?
What do I do? Yeah, so I actually am in a wonderful position to be able to do both clinical work and research work. And I love having both, and I love to maintain both in my practice because seeing patients, so I spend 1 day a week seeing patients with MS here at the MS Center at Columbia, okay. Who have cognitive complaints. Mm-hmm. Either they have cognitive complaints or they just want to get a baseline, which would be the other reason that you would come for a cognitive evaluation.
Okay.
And we can talk a little bit more about that. But the rest of my time I spend doing research. And in particular, I'm interested in exploring the neural basis of cognitive impairment in MS with an eye towards developing treatments, because right now we have no treatments.
Don't I know it?
Yeah.
How do you separate, and I hope you'll forgive me terming it Cog Fog, but it makes the most sense for me. How do you separate Cog Fog from, just like misplacing your keys, for instance? I mean, is there a way to recognize when it is happening and when it's just sort of a lapse in memory?
So that's a really key question that you're asking. And I think it's at the heart of what is so distressing about cognitive impairment for people with MS. It's this constant questioning of, is this real or is it just in my head? Is this what everybody goes through? Is this what it means to be 40 or 45, or I just turned 50 and is this my new normal?
Right.
So I think that is at the heart of the matter for people with MS. And one thing that I really spend a lot of time doing is simply validating for them. Look, if you're waking up feeling like there's something going on with your cognition, you're the expert of that. You're probably right. So you don't need to second guess yourself. Coming to see a neuropsychologist to get a baseline so that you can then know, where you were 2 years ago versus now can help a little bit. Yeah. But our measures are not as sensitive as some of the things that people with MS describe to us. So I could test you and I could say, you know what, Kathy, you're just fine because my tests tell me that you're in the average range. And you could say to me, you know what, Vicki, I'm not an average person. This isn't where I should be. Yeah. So it's a tricky thing, but there is real cognitive impairment in MS, and so people can feel validated in that. Yes.
Knowledge. It's so good to hear you say that, because that is something that we struggle with a lot. I mean, just the fact that it's an invisible disease and people question that. And then when you try to explain some symptoms like Cog Fog and they say, oh, I do that same thing. I have the same issues. I'm thinking, no, you do not.
Yes. My patients say that to me all the time.
Yeah, it's pretty maddening. Yeah. What would you say are the leading causes of Cog Fog in people? I mean, is it disease? Because I recognize that you focus on MS, but obviously, as you started saying at the top of this interview, it's pervasive in other things as well. So, is it mostly disease, medication, stress, lack of sleep, all the above?
Oh, yeah. What a huge question you've just asked.
Sorry about that.
So, no. I mean, the first thing that comes to mind when I formulate an answer to your question is a debate that I have with a colleague, where in cognitive neuroscience we always talk about cognitive changes related to healthy aging or normal cognitive decline, and my colleague always says to me, cognitive decline isn't normal.
Right.
Just because it's going on and it's a part of aging doesn't mean that it's normal.
Because it's pervasive doesn't mean it's normal and we should accept it as so.
Well, so my problem with that argument is as our bodies get older, our bodies deteriorate and we see the functional consequences of that. So with every single part of the body, an organ of the body, we see deterioration with aging. So that's normal aging.
Right.
And so why should the brain be a special case, I guess is the way that I think of it.
Interesting. So is there a leading cause you would say, or is it all interdependent and it depends on that day?
Well, so if we can we rein this in a little bit and talk about MS?
Okay, sure.
Otherwise, I'm
way out there.
I'm going to start talking about God and stuff.
Right.
I don't know where the limits of this conversation are.
Okay, within the confines of MS, is there a cause for Cog Fog?
So that's a very good question, and the answers are many. There are many answers. What we try to do from a research perspective is isolate the respective contributors to cognitive impairment. And so we look at things like lesion load, atrophy. We look at disease markers to see how closely they correspond to cognitive function. And the answer is not extremely well. There's still a whole lot of variance left unaccounted for in somebody's cognitive performance. So you can't take somebody's lesion load and atrophy and age and sex and level of education and IQ and put them all into a formula and get a precise and perfect correspondence with their cognition. There's something missing. There's something that we're not capturing in all that. And the things that I think are in that open space are things like mood, things like cognitive enrichment, which is essentially there's a theory called cognitive reserve, which speaks to this disconnect between what we predict and what we actually see.
Mm-hmm.
And it was actually formulated right here in the division that I'm a part of here at Columbia University by my big boss, whose name is Yakov Stern. He came up with this theory of cognitive reserve, which essentially says, why does everybody with the same amount of disease in their brain, and he formulated this theory for Alzheimer's disease. So he said, why do people with the same amount of disease in their brains look differently? So some people, when they die and on autopsy, we look at their brains and they have tons of Alzheimer's disease pathology, but they died with normal cognition. And so the question is, how were they able to sustain that?
Yeah.
And we can ask the same question in MS. How are people with different levels of disability? And we can ask it, by the way, outside of just cognition, right? How come there's not a complete concordance between how much disease you have and how you look clinically?
Sure.
And the answer is lots of environmental factors and things like how you live your life, how you use your brain, how you have been using your brain over the course of your life, what you eat, whether you exercise. So my research is in particular focusing on these, what we call modifiable lifestyle factors, and understanding how the things that we do, the things that we have control over, can protect us from the disease that we have.
Yeah, that's interesting. I was reading some of your work, and we're going to get to that in a minute. But I wanted to ask you, so when I was doing my research for this, I read, according to the National MS Society, that more than 50% of patients experience Cog Fog at some point in the course of their disease. Do you think that's an accurate number? Because in my experience, I'd guess it's much higher.
I think it's very hard to come up with a prevalence rate for a few reasons. So first of all, I have to say, when you use the term Cog Fog, to me, that suggests something that's like fog, something that's transient,
right?
Something that passes through. When I talk about cognition in MS, I tend to use the term cognitive impairment because I think that we see a change in stable cognitive status. When people say to me, I have Cog Fog, or I just have these days where I'm really fuzzy, sometimes I feel that there is something different about that. And so capturing that and understanding that. So I'm going into this tangent because in order to answer your question, I think there are different questions to be asked. So is the prevalence of people who experience transient changes in their cognitive status higher than 50%? I bet it is.
Yeah.
Is the prevalence of people who have cognitive impairment, that is essentially an altered baseline, is it higher than 50%? I think it's lower than 50%. Things that I'm seeing in my own research in samples that I look at are starting to suggest to me that those prevalence rates, which kind of came about in the last 10 to 20 years, are perhaps out of date. And the reason that I think that's the case is because of our disease-modifying therapies. We're actually doing a very good job now of providing patients with options for therapies that are quite effective at reducing disease activity and prolonging the time to decline. So I think that that's conferring an advantage for cognition.
Good. We'll take all the advantage we can get. Thank you very much. So at what point do MS patients, I was going to ask, or anyone with a chronic condition, but let's keep it with the MS patients that are experiencing brain fog. When do they, or when should they see a neuropsychologist? And what does that look like? Like what, I want you to share with everyone what types of tests you do and what a typical exam is like with you. I have gone through this several years ago, and I can tell you that I don't remember being that tired.
Okay.
I was exhausted when I came out of there, and I felt like I had failed a test or
inflated.
Yeah, I really did. I really did. But I think it's very important, specifically for me, to have a baseline. So I understood the reasoning behind it and the importance of it. But I'd love if you would share what a typical examination would be like with you.
Sure. So I am very sensitive to what you just raised, the point that you just raised of coming out of there and feeling exhausted and kind of defeated. I don't want to do that to my patients. I try to keep my evaluation very brief. There are a few essential tests that I need to get, that I want to get. Before I get into that completely, I'm going to answer your very first question, which was, when should somebody come to see a neuropsychologist?
Okay.
And I think the sooner the better, because I think you do want to get a baseline.
Yeah.
Baseline can be particularly important if, for instance, you ever do notice a change in your cognition, which may be subtle, and it may be too subtle to pick up on testing as putting you into a category of impaired.
Mm-hmm.
So once you get a test back from a neuropsychologist that says you're in the average range across the board on every test till Sunday, if you take that to try to build a case for disability, they're going to say, well, but you're fine because
Right.
you're average on everything. You're not impaired in anything. Mm-hmm. And as I said before in this interview, you may not be a person who's been living in the average range. So you
Right.
might say, but for me, that's a decline. Well, you need to substantiate that.
Mm-hmm.
So that's why baseline testing is so important.
Makes sense.
Generally, what happens here at our center is your neurologist will refer you for neuropsych testing. Mm-hmm. Then you'll get an appointment with me. We make sure that your insurance covers it before you come in, because we don't want somebody to get a surprise on the other side. I'm very sensitive to these sort of realistic kind of logistic concerns. I understand that patients are spending money, spending time. Sometimes they're taking a day off from work, precious mm-hmm. time that they don't have, all to have this cognitive evaluation. I want it to be worthwhile for them. I want it to be value added. I don't want it to be just another box to tick off on the medical chart.
Nice.
So I really, and I like to keep it short. So I spend about 2 hours with patients, which if any neuropsychologists are listening right now, they're cringing, because that's really unusually short.
That's a lot shorter than mine. I can tell you that.
Yeah. And some neuropsychologists spread it out over 2 days. Again, I just don't want to do that to patients. I don't want to put you through that. I know what it's like to try to, travel to the medical center and find parking, all these kinds of things. Right. I want to do this in a way that works for you and that's going to help you.
That is great.
So when you come for your appointment with your neuropsychologist, you'll be in a quiet room, just the two of you, and you'll be administered paper and pencil tests after probably an interview that takes place where we gather all of the sort of pertinent pieces of information, and try to look at an overall picture that can get at some of those other factors that I talked about before that can contribute to cognition, such mm-hmm. as your habits, your exercise, your diet, your mood, these kinds of things, mm-hmm. fatigue. And then we get into the testing. Now, you might notice that I said you're going to be in a very small, quiet room with one neuropsychologist. Mm-hmm. And what you're there for is to gain a better understanding of why you're not functioning optimally in the real world. Well, there's nothing about that contained little environment that I just described that's like the real world.
The real world, right.
Right.
True.
So you're coming in and you're taking these paper and pencil tests, and maybe you're actually doing pretty well on them. And at the end of it, I could sit back in my chair and say, you know what, Kathy, you're fine. Look at how you did on these tests. And you're saying, but this isn't what my life is like.
Right. Yeah.
This is, and one thing you mentioned very early on was multitasking. Multitasking comes all the time, patients with MS, and one thing in particular they described to me, they say, if I'm doing something and I get interrupted, I can't go back to what I was doing.
It's like back there.
Mm-hmm. Yeah. Which I guess is the essence of multitasking.
Right.
This is something that we have a very hard time capturing in the laboratory environment, the clinical mm-hmm. environment.
Sure.
We don't really have a test that's honed to pick up on that.
Mm-hmm.
So this is an example of when a patient is saying there's something going on with me, and we don't have a great tool to measure. So I think that we need to improve and hone our tools to more specifically capture the types of things that people with MS are telling us.
Mm-hmm. Well, first, let me thank you from the entire MS community for being so conscious-minded and thoughtful in the way that you're approaching this and thinking of your patients. And I wish that the person I met with years ago would have done the same because it was not a good experience. I
Oh,
can
I'm
tell you
so
that.
sorry.
Important.
Let me apologize on behalf of my field.
Well, I recognize the importance of it. So I was grateful that, I did it, and I hope not to have to do it anytime soon. But, I read again during my preparation for this that sort of the causes for Cog Fog are things like damage to our myelin sheath, thanks to our lesions and depression and chronic fatigue and anxiety. Those are all super common symptoms of MS. So how do we try to mitigate the ravages of Cog Fog? Because I have to tell you, this is my personal most hated symptom. It happens in an instant without warning. It's embarrassing. It's really embarrassing. It can be frightening. I mean, it is flat out awful. So, what causes this?
Yeah. So many questions in there.
No, I'm sorry.
Yeah, no. I think, one avenue to getting towards understanding what causes it. Look, MS is a disease of the central nervous system. That means the brain and the spinal cord. Mm-hmm. We know that there are lesions distributed throughout your brain. We know that there's demyelination. We know that there's atrophy. Of course there would be cognitive impairment, right?
Yeah, right.
I mean, rather than asking what causes this, a different way of approaching the situation might be to say, how are some people spared from cognitive impairment?
Good point.
Right?
That is a great point.
With all those things going on and damaging your brain, what's allowing some people to withstand that? And what would allow people who are experiencing it to recover from it, to perhaps remediate it? What are the opportunities for neural regeneration that might have consequences for cognition? Mm-hmm. These are the kinds of questions that I'm asking with research. And right now, again, just to go back to, I really want to reinforce that our very best evidence right now in any condition, so aging and Alzheimer's, for example, as well as MS, is not for pharmacological treatments. It's actually for modifiable lifestyle factors. And I think that this is something that's very hard for people to wrap their heads around, because we're all envisioning that at some point there will be a wonder drug. And let's hope that there is.
Yeah, give me that pill, would you?
Yeah, absolutely, right? But one thing that I say to my patients all the time is that if you examine the scientific evidence behind aerobic exercise, if aerobic exercise was in a pill, everybody would be taking it.
Right.
It's amazing. Yeah. It's not, this isn't soft science. This isn't fluffy. This is real impact on generation of neurons in your hippocampus, improvements in memory, improvements in mood, fatigue. So something like, exercise,
right.
It's a hard sell. It's a hard sell for people with MS.
Right.
For anybody, not for people with MS, for
right.
all
everybody.
Of us.
True. But right. So that you bring up such a great point. So again, in researching for this, I read a lot about exercise across the board, but in particular, as you pointed out, aerobic exercise, which disappoints me, frankly, because I don't like it, but whatever. If it can help, I'll step it up. And the increase in brain plasticity and the clarity that people report after having done some aerobic activity, I think is really pretty darned exciting. Mm-hmm. So obviously everyone is different and should first check with their doctor, but on the whole, would you say that aerobic exercise in particular, I mean, all exercise is good, but aerobic exercise in particular, would you say that is helpful with Cog Fog?
Absolutely.
And so how much? I mean, again, everybody's, different, but
no, I'll tell you how much.
What's showing optimally, how much, how often should we be doing?
I'll tell you, it's kind of coming down to 3 times a week, half an hour.
Okay, aerobic. That's better than I thought.
It's not crazy. It's not over the top. And so here's what I say to my patients. I say, look, you have to find what you like. You have to find the type of exercise that you like, or else you're not going to do it.
Right.
And you have to incorporate it in your life in a way that you like. So I'll tell a little show-off story here. I decided to run a marathon 10 years ago. And I decided, because my favorite drinking buddy from college told me that he had run a marathon, and I felt totally betrayed and totally competitive. Like,
that
are you
is
kidding me?
That's great motivation, though, right there.
We were not jocks at all. So I was like, all right, if he can do it, I can do it. I'm going to do this thing. But I made an agreement with myself that I wasn't going to do it. So to me, and I wasn't even a runner, to me, the idea of exercise was inextricably linked to pain and discomfort.
Yes, agreed.
I decided, you know what, I'm going to do this, but I'm going to make it mine. I'm going to do it in a way that's not painful and doesn't impose discomfort. So I'm not going to go running at 5 o'clock in the morning, and I'm not going to go running 6 days a week. And I'm going to do it. I'm going to take it nice and easy.
Do it your way.
And I wore a turtle bracelet around my wrist when I ran the marathon, because that's me. I'm the turtle. I'm slow and steady wins the race. So I say to my patients, find something that you like and do it in a way that it doesn't disrupt your life. Right. Find the way. You have to. And it's the most essential thing. So if you're going to start once a week, if you're going to say once a week, I'm going to do some stationary cycling. Maybe that's the exercise you like. Mm-hmm. Maybe you like being on a Stairmaster at the gym with a TV screen in front of you. Or maybe you like going for a jog along the river outside, by your house. Whatever it is that fits with your life, find that thing, because that's how you can incorporate exercise forever.
Nice. That makes sense. Okay, the exercise, and by aerobic we mean getting the heart rate up. Just to clarify a little bit, because my favorite exercise is yoga, and actually the very last pose, the shavasana, where you're just laying there in corpse pose. That's my favorite, and I have mastered it. I'm the best. But okay, I'll do some more aerobic stuff.
Sometimes yoga gets you into the higher heart rate.
Well,
depends.
Not the way I do it. But okay, maybe I'll push it a little more next time. Mm-hmm. I also know that diet plays quite a role. You sort of alluded to that earlier. I've read that sticking to a diet like the Mediterranean diet helps. High in fish, high in the omega-3s. Is that what makes the difference?
So far, that's how it pans out. So one of the researchers here in my group, Jan Gu, is doing a lot of this work in aging and Alzheimer's. And so I have the privilege of being able to hear her hot off the press, or not even off the press, pre-press findings that she's doing. Every time she stands up to give a talk, she's breaking it down into nutrients and micronutrients and patterns and da-da-da-da-da. But then she brings it back to food, and I always walk out of the room going, fish, we just got to eat
more fish. Yeah.
It always comes down to fish.
Okay.
And olive oil.
Fish and olive oil and veggies, right?
Veggies. Well, so it is classically, it is framed as the Mediterranean diet.
Yeah.
I have a friend who's like, what does that mean? I should go out and eat a gyro?
I like your friend.
We don't exactly know what the Mediterranean diet is in our culture. So right. I think it's good to just say, fish, vegetables, grains, olive oil is just always comes out as one of the constituent factors in this diet.
Okay. All right.
Nuts, walnuts. Great.
Yeah. Right. Yeah. Seeds.
Yep.
So I have also noticed that when I'm tired, the Cog Fog seems much worse, but fatigue is a daily companion for a lot of us, and many of us have trouble sleeping to top it all off. So how do we get enough rest so that doesn't turn into, more of a Cog Fog event?
Right. So there's fatigue and there's sleep.
Right.
I think these are very, very different topics. Let's talk about sleep first. For sure, sleep is neuroregenerative. Sleep is when your brain repairs itself. And we're actually we have some preliminary results from a study that we're doing right now, which are showing that sleep may actually be a very powerful mediator of new lesions and atrophy.
Wow.
So it truly is your brain repairing itself and working to fix what's broken before it has a lasting consequence. That's how I see that mediation between lesions and atrophy. I think that's really striking, actually. And it really argues for the importance of sleep, getting into a good sleep routine. That said, it's clear that people with MS have challenges around sleep, which are not easily addressed. Things like urinary incontinence and things that, interrupted sleep, not even to touch on insomnia and these kinds of things.
Right.
So for each patient, who tells me that they have sleep problems, I like to break it down and figure out what is the etiology, what's going on behind this. There's actually an app on the market now called Shut-Eye. It's SHUTI.
Okay.
And it's a cognitive behavioral based treatment regimen. It's self-directed, so you download the app. Now, I'm going to say this right now because I recommended it to a patient the other day, and then as I was talking to her, I looked it up. It's not cheap. This is not free or $1.99. It starts out somewhere around $150 for a year, I think, or maybe a half a year. But so I was a little taken aback. But then I researched it a little. It's very, very well supported. I don't have any involvement in this company. I'm not pitching my product here.
Right.
There's an astonishing amount of evidence behind its efficacy.
Oh, excellent. Oh,
this is for people who have insomnia. This is not for people who have a number of the kinds of things that might be causing sleep interruption for people with MS. So it's important that we're like targeting the right people here.
Sure.
But if you're struggling with sleep issues that are more related to insomnia, I'd say have a look and check it out and see, because patients have been telling me that it's really effective for them too.
Excellent. Well, thanks for that tip. I appreciate that. So what other underlying conditions or sort of low levels of, as I'd call them, could affect cognitive function? I know that my doctor always checks my thyroid levels, for instance, and I know that can impact clear thinking. Are there others?
Well, I want to talk about mood for a second because we haven't really gotten into that. And this is something that I talk about with all of my patients because, and I say to them, look, I'm asking you about mood because it's something that we actually can treat. We actually have we have a number of tools in our armamentarium to treat depression. And if that's what's causing secondarily these cognitive changes, well, then let's go at it from that direction.
Yeah.
Because some people, and well, I won't designate particular groups, but I am talking about men who have a harder time entertaining the notion that they might be depressed. Look, there's a lot of women also who don't want to be told that they're depressed. Right. And one thing that I find myself explaining to people sometimes when they have this knee-jerk reaction like, well, I'm not depressed. I'll say, depression doesn't look the same in everybody. Depression doesn't necessarily mean you go to bed with a box of tissues and a box of bonbons and watch TV all day. Depression can also manifest as irritable and angry. And sometimes when I say that to patients, I see that it resonates with them.
You just described the country right now. So sorry, that was an aside.
A national depression.
Yes, I think so. Kind of irritable and angry.
Yeah.
So you sort of try and suss that out first and then treat that. And by treating that, then
yes. Well, it's like a layer. And if we can at least, well, first of all, let's treat depression for depression's sake, right?
Right.
But depression causes, guess what? Memory impairment and slowed information processing speed. So the cognitive profile of depression looks very similar to the cognitive profile of MS.
Right.
So if we can separate these two out.
Are you including anxiety under sort of the umbrella of depression, or are those two separate things?
Anxiety is different. And so it's also going to have an impact.
Yeah.
One of the things that I look at in my research is actually personality traits that put people at higher risk for cognitive impairment. The personality trait that emerges above all others as being a risk factor for memory impairment is neuroticism. Neuroticism describes a stable tendency to have a maladaptive reaction to stressful situations. So that kind of sounds like
wow,
right?
Yeah, I got to unpack that one.
Yeah,
what
I think it's closely related to anxiety. It's a personality style of people who tend to have high anxiety.
Yeah,
and it's really remarkable how the sort of relationships that are emerging. What we're seeing is that people with high neuroticism have worse memory and are at higher risk for memory impairment, and that relationship is mediated by hippocampal volume, which is basically the hippocampus is this little area in the middle of your brain which is where memories are formed.
Yeah.
So it's a highly important part of your brain.
Hard worker.
What's that?
It's a hard worker.
It's a hard worker, yeah. And it's really nestled deep inside your brain. You have a left and a right hippocampus, and they're like little walnuts that sit side by side right in the center of your brain. I like to think of them as sort of like in the safest part of your brain, because they're deep, deep down. And there are two sides. It's a uniquely plastic area of the brain, which is bad because it means that they're uniquely susceptible to transient changes, things like neurotoxic effects of pregnancy and neurotoxic effects of stress, these kinds of things, the hormones that are released during stress, acute stress and chronic stress. The flip side of that, which is the good news side of that, is that neuroplasticity goes in two directions. So while it's uniquely vulnerable and suffers from atrophy and cell death as a result of these types of neurotoxic things that I just described, it also regenerates. It's one of only two areas of your brain that will constantly regenerate cells for the rest of your life. Isn't that amazing?
That is amazing, and it's my new favorite part. Yay, hippocampus, you can do it.
I tell my patients about this all the time because it's like, one thing that I say to my patients is, if you're worried that your brain is slowly dying, stop worrying. It is.
Yeah, right. Yeah.
For you, for me, for all of us, unless you're under the age of 21. For the rest of us, it's just a slow and steady downhill slope, with the exception of two areas, the hippocampus and the other one, which is wacky and who knows what it means, but your olfactory cortex, your sense of smell.
Oh, wow.
You're regenerating neurons in your olfactory cortex for your whole life. I think that's fascinating and amazing.
That is fascinating. Huh.
We don't know why it's important because we don't know much about olfaction because it's so freaking hard to measure. But
wow, that is really interesting stuff.
Yeah.
Wow. I'm trying to take all this in. This is really interesting. Well, I was going to say too, for me, I will get highly stressed. And that's when I really certainly notice some cog fog, but I've learned to do things like deep breathing, something to relax myself. I close my eyes and I sort of go to my happy place. It really calms me down. And I literally can focus again if I just will give myself a break and just do that. So I know I read that you do make suggestions for meditation and that sort of thing. I would imagine that's, if you can get people to do it, it's got to be really helpful.
Yeah, I actually think that, there's a lot of emerging evidence around things like meditation and mindfulness. And I think that some of the benefits of those sorts of things are actually overlapping with the benefits of shock awe, aerobic exercise.
Oh, there it is again.
I do. And yoga. I think that it has to do with taking our minds out of something that we're engaged in and focused on and letting our minds be free to sort of wander. This sort of activity for our brains actually enhances a network of our brain, which is called the default network, which has become a central area of my research in MS. Understanding the default network and how it relates to our cognitive function and our cognitive health overall. The default network is a collection of regions of the brain that are more active when we are not task-focused. And activation in this network and connectivity among the regions involved in this network is correlated with things like sleep. It's correlated, activity in these regions is increased during meditation and during exercise. And activity in these regions, connectivity of these regions is associated with better memory and better cognitive outcomes.
Nice.
So I have sort of a wacky working theory in progress about the fact that as human beings, our generation, I think, spends less time in this non-task-oriented state than prior generations.
Absolutely agree. But first, let me thank you for including me in your generation, because you can't see me, but I am not. But anyway. I am much older than you are, but thank you. But I totally agree. I know what you're saying, and I completely agree when I think about, my parents and the time that they would spend, oh my gosh, walking, fishing,
Mhm.
floating, on the lake, that sort of thing. And that is unfortunately rather unthinkable for me. I don't have space in my life for that, which is really kind of dumb.
Well, and even going back like hundreds or thousands, let's go back thousands of years, people had to work. They had to work the land, they had to be out hunting and gathering, and that kind of physically rigorous activity left their brains free to
Right.
rove and roam. And now we're pretty much using our brains for focused mental activity all day long and very rarely using our bodies. I think this is one of the reasons that exercise is so beneficial, is when we're exercising, our bodies are active, but our minds are free to roam.
Mm-hmm.
And that's what's good for our brains. Just like sleep is restorative, I think brain roaming is restorative.
Oh, I like that. I might start a brain roaming club. I like that because I have trouble focusing anyway. So just give in and let it roam and say, I'm doing something for myself right now. I'm letting it roam.
Yep.
Oh, I love it. So to sort of recap then, we should eat well, especially fish and veggies. We should get exercise, especially aerobic. We should get plenty of rest. Check for underlying issues and treat appropriately. We should do some type of de-stressing activity. We should allow our brains to roam.
We should bring our neuroticism levels down.
Okay, well, good luck with that one. Do you have any other tips or tricks that you can add to this list, or is that?
Yeah, and actually I do, and I'm gonna link it to the neuroticism one. Another line of my research that I'm interested in right now that I'm pursuing, and I've just been funded by the National MS Society, is social support.
Oh,
I think
good
that
one.
social support is so incredibly important to us as human beings and
I agree.
so overlooked.
Yeah,
And
great point.
I think people with MS, at a time when we need support, we need to be able to lean on others, are actually, in many cases, doing just the opposite, which is retreating from their friends and families. And I think cognition is actually a big cause of that. I don't think, my patients have told me this. I learn everything that I know. I meant to preface this whole thing by saying that everything I know about MS that's really important, my patients taught me.
Nice.
And so they've told me, I've actually cut ties with my closest friends because I don't want to tell them what's going on with me. I'm embarrassed by it, or I feel like they don't understand it. It makes me feel angry, but I don't want to feel angry towards them. All these levels of things. And that ultimately, I think their personal relationships suffer. And what I've come to do, because I felt like as a clinician, sitting across from a patient who's telling me how isolated and alone she feels and how she feels like no one understands her, and thinking to myself, gosh, that's what my morning patient said to me. I wish you two could meet.
Right, exactly.
I mean, I came to feeling like I actually have an ethical obligation to bring people together so they can share, so that they can not feel isolated. I can't sit here and listen to another patient tell me how isolated they feel.
Right.
So I started something that I call e-support, which is an online support group. And we actually run them we use a Zoom link. So it's a private, closed link that we keep the group small. And the reason I wanted to do this was because, again, getting people to come to a medical center once a week for support group as a way to sort of reduce stress, well, that trip becomes a stressor in and of itself.
Absolutely.
So now you've kind of, negated the benefits.
Right.
That's number one. The other reason I wanted to do it through a video link online is that a lot of people, when I say to them, have you ever been in a support group? A lot of patients say this. They say, I'm a little bit scared to walk into a room full of people who may have disability worse than my own. I'm worried about how I'm going to feel if I see that. Well, guess what? When you're on a video link, you don't know what's going on with people unless they want to show you.
Right. Oh, that's
so,
brilliant.
It's like Hollywood Squares. You've got these little floating heads. And people can reveal whatever they want to reveal about themselves.
Right. Oh, that's brilliant. I love it. Yeah. What you say rings true for me as well. I mean, I limit my time with people because I don't want to show particularly when I can feel this cog fogginess coming on, or I'm tired, and I do get tired much quicker than I used to. So I am limiting you're really bringing up a lot of things that I hadn't thought through, but you're absolutely right. And, I just saw some friends this weekend, and when I left, I said to my husband, that was soul filling. Just being with them, I felt I got so much out of that. And I actually had a lot more energy than I normally would. And so to your point, I think that's brilliant. Make connections and stay connected and support each other.
And Kathy, it's amazing because now that I'm really thinking a lot about this research-wise, it's one of those things, like I see it everywhere in the world. Everywhere I look, the World Health Organization just designated loneliness as a risk factor for health, for poor health outcomes. So there is this recognition of how important we are for helping each other, and how important social support is, and how detrimental social isolation is.
Right. Brilliant. Oh my gosh. Well, Dr. Leavitt, thank you so much for being here with us today. I so appreciate it. And you gave us some great tools for dealing with what can absolutely be debilitating to so many of us. I appreciate your work in this area, and I appreciate you taking the time to talk with me today. Now, if others want to learn more about your work, how can they find you?
Well, thank you, Kathy. It's been my pleasure speaking with you. If anybody wants to come find me, you can go to columbiadoctors.org and just type in my name. And you can find my research by Googling my name. There are a number of publications out there. So, and if you do come across me online and find a way to email me, I'd be happy to be in touch to answer additional questions.
Perfect. Excellent. Well, again, thank you so much. Great meeting you. And maybe I'll see you in eSupport one day.
Thanks, Kathy. Okay.
Take care.
Bye.
Thanks, everybody. I really appreciate you listening to the FUMS podcast show. Be sure to subscribe to it so you won't miss an episode. You can do that right on the website at FUMSnow.com. While you're there, sign up for the free email list so you'll be among the first to know of any new findings in MS research, new therapies and products, as well as any blog posts and podcast episodes I release. Want to chat with others in the FUMS community? Join us on Facebook at FUMS Now. Thanks again, and don't forget to talk to this stupid disease as it deserves. Tell it FUMS every day.